All right, let's dive into a topic that really shows how medicine evolves: endocarditis prophylaxis. For decades, the thinking was better safe than sorry, leading to a very broad strategy. But a huge reevaluation of risk has completely changed the game, moving us toward a much more precise approach. So, let's get into it.
So here's our game plan. We'll start with the disease itself. Then we'll track the massive shift in prevention that got us where we are today. After that, we get practical. Who's high risk? Which procedures matter? What's the right antibiotic regimen? And we'll wrap it all up with some real-world case studies to make sure it all sticks. Okay, first things first. Before we could talk about preventing a disease, we have to really understand the enemy we're up against: infective endocarditis.
So, what exactly is this? Well, infective endocarditis is when microbes get into the bloodstream and set up shop on the inner lining of the heart, especially the heart valves. Now, it can come in two main flavors. You've got the acute, really aggressive form, often caused by nasty bugs like Staphylococcus aureus, that can hit you like a ton of bricks. Or it can be this sneaky, subacute illness that just simmers for weeks or months with vague symptoms, making it a real nightmare to diagnose.
And you do not want to mess with this condition. The stakes are incredibly high. See, these little bacterial colonies, or vegetations, are fragile. They can break off and become tiny guided missiles of infection. If they launch from the left side of the heart, they can travel to the brain and cause a stroke, or they can hit organs like your spleen or kidneys. And locally, the infection can just chew through your heart valves, causing heart failure, or even tunnel into the heart muscle itself. It's serious business.
The way it develops is like a three-step recipe for disaster. First, you need some initial damage to the heart lining, maybe from turbulent blood flow. This creates a tiny, rough patch, a perfect sticky spot for bacteria. Step 2 is bacteremia, bacteria getting into the bloodstream. Then, for step 3, if those circulating bacteria find that sticky spot, they latch on, multiply, and form one of those dangerous vegetations. Now, prophylaxis isn't aimed at step 1. It's a strategic strike aimed squarely at step 2, to wipe out the bacteria in the blood before they can ever find a place to land.
And that realization that bacteria in the blood is a common, everyday thing was the spark that ignited a total revolution in how we approach prevention.
For more than 50 years, the logic was pretty simple. Certain procedures let bacteria into the blood, and that can cause endocarditis, so let's give antibiotics beforehand. It made sense, right? This led to a very broad, shotgun approach. But then came 2007, a landmark year. The American Heart Association and soon everyone else took a hard look at the evidence and slammed on the brakes, dramatically narrowing the guidelines.
Now get ready for this, because this one idea is what flipped the entire strategy on its head. It turns out that the amount of bacteria that gets into your blood from just daily life, like brushing your teeth, dwarfs what you'd get from a single dental visit. Let that sink in. We're constantly showering our bloodstream with tiny amounts of bacteria, so focusing all our efforts on that one dental procedure started to look like trying to empty the ocean with a teaspoon. When you weigh that against the very real risks of antibiotic overuse and resistance, the old way just didn't add up anymore. Okay, so if we're not giving antibiotics to everyone anymore, who does get them? The new strategy is all about focusing on a very, very small group of people where the benefits clearly outweigh the risks. The guidelines are incredibly specific about who's in this exclusive club.
The list of who qualifies is incredibly short. We're talking just 3 groups, that's it. Group 1, anyone with prosthetic material in their heart, like an artificial valve or a repair ring. Group 2, anyone who has had endocarditis before. These folks are at the highest risk of getting it again. And Group 3, a very specific slice of patients with congenital heart disease. It's a really short and exhaustive list. Things that used to be on the list, like mitral valve prolapse, they're out.
All right, so finding a high-risk patient is just part 1 of the puzzle. You also need part 2, a high-risk procedure. You have to have both. It's like needing 2 keys to turn the lock. One without the other doesn't work.
The list of procedures is just as restrictive. It basically boils down to 2 main scenarios. First, dental work that involves messing with the gums or could cause bleeding, and second, cutting into infected tissue, like lancing a skin abscess. And just as important is what's not on the list anymore. Things like a routine colonoscopy, getting a pacemaker, tattoos, nope. Even for the highest-risk patients, these procedures don't get prophylaxis.
Let's zoom in on dental work, since it's the most common reason for this to come up. The rule of thumb is pretty simple. If it's likely to cause bleeding from the gums or deep tissues, it's on the list. We're talking tooth extractions, periodontal surgery, placing implants, but things like getting a filling, a simple anesthetic injection, or getting x-rays, those don't require it.
Okay, so you've got your high-risk patient and your high-risk procedure. Check and check. Now what do you actually prescribe? The goal here is simplicity and effectiveness.
And the beauty of the modern guidelines is how simple this is. We're talking one single dose of an oral antibiotic taken about 30 to 60 minutes before the procedure. That's it. And the choice of antibiotic is smart, not random. For dental procedures, you're targeting the common mouth bugs, so amoxicillin is the go-to. For a skin abscess, you're worried about skin bugs like staph, so you use something like flucloxacillin. Allergic to penicillin? No problem. Clindamycin is the backup.
All right, theory is great, but let's see how this all plays out in the real world. Time to run through a few cases to put our knowledge to the test.
Okay, case number 1. You have a 65-year-old patient, they have a bioprosthetic aortic valve, and they're scheduled for a routine screening colonoscopy. So what's the call? Prophylaxis, yes or no?
The answer is a firm no, and this is the perfect example of that 2-key rule. The patient? Yep, they're high risk because of the prosthetic valve. That's key number 1. But the procedure? A routine colonoscopy isn't on the high-risk list. So we're missing key number 2. You need both. No prophylaxis.
On to case number 2. A 45-year-old patient with a permanent pacemaker. They've got a large skin abscess that needs to be incised and drained. What are you thinking here?
And again, the answer is no. This is the flip side of the last case. This time, the procedure, lancing an abscess, is definitely high risk. So we've got that key. But the patient? Having a pacemaker doesn't put them in that very specific high-risk cardiac club. So again, 1 out of 2 isn't enough. No prophylaxis needed.
All right, last one, and it's a little tricky. We've got a 7-year-old child. They had a heart defect, a VSD, repaired with a patch 3 years ago. The repair is perfect, no issues. Now they need a baby tooth pulled. Prophylaxis, yes or no?
And the answer is no. This case is great because it highlights a super important detail. Yes, there's prosthetic material in there, but there's a time limit. For these kinds of repairs, prophylaxis is only recommended for the first 6 months. The idea is that after 6 months, the body has laid down its own layer of tissue over the patch, it's endothelialized, and the risk drops way down. Since the repair was 3 years ago, they're well past that window.
Okay, let's wrap this up with the key take-home messages. 1. Prophylaxis today is a sniper rifle, not a shotgun. It's highly selective. 2. It's only for those 3 specific high-risk heart conditions. 3. It's only for a couple of specific procedures, mainly dental work that causes bleeding. 4. The regimen is dead simple. 1 targeted dose of an antibiotic beforehand. And finally, and this is maybe the most important point of all, the best prevention isn't that single antibiotic dose. It's lifelong, meticulous oral and skin hygiene. That's the real cornerstone.
You know, when you step back, this whole story is a fantastic example of evidence-based medicine getting smarter. But it also leaves us with a pretty big question, doesn't it? After all this focus on a single pill for a single procedure, are we forgetting that the main battle against endocarditis is won day in and day out, not in the dental chair, but at the bathroom sink? It's something to think about. Thanks for joining us on The Explainer.